Morning. We're going to get started. I'm glad to hear the buzz and all the energy. This is one of my favorite events of the year at Yale. So welcome to the Future of Health Innovation Prize for StartUp Yale. Future of Health Innovation Hub is a new program of the Yale School of Public Health, supporting innovators that are looking at how to take their innovations to have public health and broader population health impacts. So we've got 4 wonderful finalists that are going to present today. I'm not going to be up here very long, but our format is each group will present. We have our judges here who will each maybe have some Q&A, and we'll work our way through the pitches. If you're sitting down, you'll notice that on your seat there's an audience choice placard. So after all the pitches, we'd like for you to select your choice for the winner. And so we always do that each year, and I think it's nice. So you'll also have a vote here to weigh in on what you think the best innovation is. So with that, we're going to get started. So our first innovator is going to be presenting is Dr. Brian with Akomapa. So it's over to you.
Your mic. Oh, your mic. Yes. It was 6:13 a.m. when I received the news that forced me into my chair. I was preparing for my patients at the Haven Student-Run Free Clinic when I heard that my grandmother had passed away. It was unexpected. My grandmother had told everyone that she was visiting the United States for the first time to watch as her favorite grandson graduated from the Yale School of Medicine. But we were robbed of that moment. She died from a silent killer, an asymptomatic, uncontrolled, non-communicable disease. Non-communicable diseases like hypertension and diabetes are the world's leading cause of death, with majority in low and middle income countries. Countries like Ghana, with 1 physician for every 10,000 patients, millions will go without diagnosis, care, or follow-up. Akomapa exists with a basis of research. To understand the problem even more, our team conducted an award-winning thesis studying the barriers to NCD care in Ghana and the role that students can play in addressing these gaps. What we found was that the system currently is not built for chronic disease management. We enumerated 5 critical care gaps, spanning infrastructure, education and awareness around NCD, insurance penetration, particularly in rural communities, cultural beliefs and systems, and the lack of human capital. So what we found was that this was not just a problem about care, access, or diseases. It was an entire system that was not built to manage chronic diseases like hypertension or diabetes.
Akomapa is reimagining NCD care. We are creating a network of student-run, expert-supervised, and community-embedded free clinics that provide longitudinal care for chronic diseases while training the next generation of healthcare leaders. So how does each Akomapa clinic work? We partner with universities, government, and communities to train students in a rigorous 6-week program. We mobilize awareness and then establish clinics within their communities. In each clinic, we screen, we mobilize people to get screening, we link patients to care, and we ensure follow-up through our Nkwapa digital platform. Our pilot, in partnership with the University of Cape Coast, was established in Ibra, and our clinics was developed in the middle of the community market, meeting patients where they already are. We had a lot of student enthusiasm and university buy-in, so we've moved into another community. And so 1 university, multiple clinics, different communities served. And so because we know that the NCD gap cannot be closed by doctors alone, we're investing in these interprofessional teams to close the immediate gaps within the communities, but also with a long-term vision of preparing the next generation of healthcare leaders to be NCD aware and NCD competent.
And we're not starting from scratch. Here in the United States, student-run free clinics serve about 140,000 patients each year. And globally, models like Shoko in South Africa have been providing care in underserved communities for 80 years. And because we know these care gaps extend beyond single communities and are systemic in many countries, what has been missing is not this proven module, it is the system to scale it.
And this is exactly what Akomapa delivers. We are creating a network of multi-institutional networks to allow us to learn from each clinic, disseminate knowledge across institutions, and standardize practice across sites. And so instead of isolated clinics, we are building a coordinated system of care and learning, one that allows us to improve faster, learn better, and scale smarter. And it's already working. We have 2 rural community clinics running, with 2 more on the way in a new partnership with the University of Ghana. We've mobilized 4 partnerships across Ghana and the United States. We've served 2,000 patients and mobilized 100 student volunteers. This is more than a concept. This is a model already in motion.
This year, we are launching our flagship programs. Our first is the Akomapa Global Health Ethical Leadership Training Program, a credits-bearing online and rigorous program to standardize training for all Akomapa volunteers. The curriculum is developed in partnership with the Yale Internal Medicine Primary Care Program and the University of Cape Coast Department of Community Medicine, with expert supervision, training all the way from the Ministers of Health in Ghana, the Provost of the College of Health Sciences at the University of Cape Coast, and the Director of the Chronic Care Access Lab here in the United States at Yale. We're also launching the Akomapa Immersion Program with a focus on community and rural health and cultural immersion. Together, these 2 programs that we will launch in this year will allow us to share our model and our learning with the rest of the world whilst generating revenue to sustain our clinics.
And so our model is built for long-term financial sustainability. We begin with philanthropy and research grants and transition into earned revenue through programs that we already control. Our goal is to be self-sustaining within the next 5 years. Within the next 6 months, we are raising $40,000 to support clinic expansion, Nkwapa development, and global health programs. We've already raised $7,000. With the support of this prize, we'll be significantly closer to our goal.
And our bold vision is driven by a team of young, spirited, and passionate leaders across Ghana and the United States with shared hearts, purpose, and science. Our leadership team and our advisory board combines expertise across medicine, global and public health, IT, business, and law.
We're doing the work. We're engaging the right people, like Auntie Comfort, a market queen who now serves on our advisory board. We are testing the model and showing that it works. The enormity of this task is not lost on us, but we can no longer sit and do nothing as young people.
And beyond the modules, beyond the numbers, I often wonder how different the story would have been if my grandmother had access to early screening and care. I wonder the pride she would have felt as she watched the first physician in our family graduate from the Yale School of Medicine. That what if has shaped my path towards becoming a primary care physician. I want to create a different story for another grandson and his grandmother. The name Akomapa has 2 meanings in my language, Akan. It means a healthy heart, but it also means a kind heart. And this dual mandate reflects our commitment towards building a future of health where you live does not determine whether you live. My name is Brian.
I'm Sedem, and
we are Akomapa. Thank you.
Nicely done. So let's do some Q&A now from our judges.
Hi, can you hear me? Great. Thank you for this. I think it's great to see you actualize skill shifting on the ground, right? So skill shifting is being used in many parts of the world, as you know, including this country. Have you looked at the skill shifting lessons? Because all have not been successful. So let me outline 2 or 3 things. Scaling with a sustainable standard is often hard when you have a volunteer workforce. And just education is not enough. My first question is, what's the role of technology, especially when you're augmenting skills and knowledge with AI in order to enhance human capacity? That's the first one. If you look at models that have faltered, even when they've done this well, it's really about the economics. Yeah. To scale every node, to get every volunteer, after all, volunteers' sustainability of having them continue is choppy. Yeah. Retention is a problem. So when you scale the cost per node is high. Most of these models work on cross subsidies, where there's an earning arm and then there is a cost arm. Your model seems to be standalone. You don't have a cross subsidy. So how do you expect to generate sustainable revenue? And the third thing I think is when you take a model and you use students, that model is fraught with the availability of students who want to do this. And when you scale across different cultures and countries, it's not easy.
Yeah.
So I guess 3 questions: benchmarking against failures and successes, use of technology, funding that's organically generated. Philanthropy will only take you to a point.
Yeah.
And fourthly, scaling beyond your own community with the concept of student volunteers.
Okay, I will take the first 2, the role of technology and our scaling mechanism, taking into consideration. Then we'll talk about our cross-subsidy module in current research, and I'll finally talk about the final question. So we decided to focus on building our tech platform in Nkwapa. Nkwapa means a healthy life. And the reason why we chose to do this was also based on the findings of our pilot research. What we found that going into communities and screening, linking to care and education, you are right, will not be enough, especially for chronic diseases like hypertension and diabetes. What we need is follow-up. And so in each place, Nkwapa allows us to track the patient's journey through the linkage to care with the larger Ghana healthcare system and ensure that they are coming back for screenings, they are getting the medications when they need to, and that we are actually making an impact looking at KPIs like hypertension diagnosis, medication access, and what have you. So the technology does not only allow us to follow up with the patient, but ensure that we are actually doing the work that we send out to do. But the Nkwapa is also the ways in which we manage our own volunteer base and ensure that students are also learning, because Nkwapa exists to also train the next generation of healthcare students. So Nkwapa also allows us to track each student's learning, the courses they are taking to our online platform, Nkwapa Academy, and what have you. And then finally, Nkwapa allows us to ensure easy workflow across our sites, because patients go through different spots. We ensure that patients are connected with the same kinds of students time in and time out. We chose to scale with universities for 2 particular reasons. Our research showed that this would run if student enthusiasm is there. Universities like the University of Cape Coast has a health professional student base of more than 3,000 students. We were initially starting with 60 students. We opened our applications. By day 2, we had already hit over 300 students. So we had to close applications early. Because we take a defined number of students, it allows us to train them more and ensure that they are ready, keeping an eye out on each student. But universities also open us access to faculty to supervise the clinics that we're doing and access to community partnerships that they already have in existence. So our research thesis showed that the legitimacy that Nkwapa will have in communities would in a long way be grounded in the partnership that we maintain with each universities. We understand that modules like this globally have not always been successful, and we are not disillusioned by that fact. And it's part of the reason why we are starting with a heavy philanthropy base, but as early as this year, are working to roll out 2 cohorts of the Nkwapa Immersion Program, as well as launch our Global Health online training platform for ethical leadership, which will allow us to train students whilst also bringing in early revenue. And so then we'll talk about our cross-subsidy module.
Right, and adding on to what Brian already very well said, we ensure student engagement and sustainable cohorts of students by partnering with the universities to make this activity a credit-laden one, so that it's an incentive for students not only to come and learn based on their own interest in learning from these experiences, but having a systematic show for their participation as part of their university education. In terms of the cross-subsidy module, we are aware of the importance of a structure like that, and we didn't mention it because it's still early in the pipeline, but we are looking at creating nutrition hubs and healthy food hubs in high-income areas in Ghana. So while the problems with NCDs are disproportionately affecting people in rural areas, it's a nationwide problem, and the failures are affecting everyone, including people in high-income communities. So what we are thinking about doing, and the model that we are researching, is establishing these nutrition hubs where people will get healthy foods, but also have nutrition services. So we'll have a dietitian available to show people exemplars of local foods that people are already find palatable, and show them how to prepare them with, for example, a DASH diet, which is hypertension protective. So that will allow.
Yeah, that's good. Thanks. No, I think we've covered. I just want to be mindful of time. Is there one more question from a judge? For anything else?
I got something.
Okay.
Yeah. So you spoke a little bit about being tech forward and the tech playing a role in being able to scale here. I saw on one of your slides it was something that was more future looking for you, but you do have a CTO. Could you tell me a little bit about how he and you together are thinking about building out the product side of this to be able to scale? And if so, if you've started building, can you tell us a little bit about that as well?
Yes, so we've already started building. Nkwapa is the MPV version of Nkwapa is already almost ready for our students to use during the next cycle of Akubapa when they go back into the communities. We started early on because one, the data that we were finding showed the need for it, and so we're also building it to be first offline. So students go into the communities, we use Nkwapa services to roll out, to track patients and whatnot, get the data onto an offline server, and when they come back to the universities where there's reliable data connection, they then continue and store the data in a secure platform. We're choosing to do this early now because we understand the role that tech will play, especially when it comes to scaling across a country like Ghana.
Wonderful. Thank you so much. You've kicked us off well. Let's give him a hand. So up next is for Eva. So over to you.
The year is 2026, and across hundreds of diseases, women still average a 4-year diagnostic delay. 56% of us report our pain being dismissed by providers, and when we show up in emergency departments suffering from a heart attack, we're 50% more likely than our male counterparts to be misdiagnosed and sent home. Maybe that's because we were only 8% of NIH funding in 2023, or because we were only included in clinical trials in the 1990s. Maybe it's because women have been denied the basic tools to understand our biology, because despite a surge in consumer health monitoring, the market has failed to react to the specific healthcare needs of women. Now, this was something I saw firsthand during my time as a medical negligence lawyer, and I knew that we deserved better. The struggle to put meaningful, insightful tools into women's hands was something I knew I could not do alone. So I came to Yale and partnered with the incredible Emily Duchesne, a brilliant biomedical engineer with industry experience, focused specifically on the female body. Now, what if I told you that Emily has been doing the really hard work in the lab to finally make things a little bit easier for women? Step up to your sink every day and let me introduce you to Fern, a smart toothbrush that analyzes biometrics in your saliva to provide personalized, accurate, and dynamic insights specific to the female body. Not always on, but always part of your morning routine. Now, why saliva? Well, it's a bodily fluid that can be collected non-invasively and, in our embodiment, as part of your everyday oral hygiene routine. Importantly, the accuracy and precision of salivary insights for health goes beyond current crude proxies, such as temperature and heart rate. Instead, saliva is a direct snapshot of function, yielding richer, higher quality data. It's also cheaper and easier to collect compared to blood and urine, making daily measurement accessible for the first time. And, most importantly, saliva is rich in detectable biomarkers. In fact, that list is so long that our provisional patent doesn't just extend to 1 or 2. It extends as a platform approach to detect and measure 88 different analytes that can have profound impacts among multiple categories of women's health. giving women the tools they need to finally understand their own bodies. So the question then is, what comes first? Well, we're starting with the reproductive endocrinology brush because we're following the science. We know it makes sense to measure these hormones on a daily basis because they reliably fluctuate depending on menstrual cycle phase, causing whole body impacts. We also know that estrogen and progesterone in particular are key hormonal variables in many of the diseases we want to study in future, such as bone, brain, and heart health. So starting there makes sense. And lastly, we're confident that providing women with menstrual cycle insights without physician oversight is not only ethical, but actually useful. So what do we mean by useful? Well, reproductive hormone monitoring has 3 broad use cases. 1, fertility. Hormonal concentration data goes beyond wearable temperature correlation, a method that only achieves a true positive for ovulation 54.9% of the time, to pinpoint ovulatory windows and also monitor post-ovulatory progesterone, which, when low, doesn't always affect temperature or cycle length, but significantly drives early-stage pregnancy loss. 2, hormonal imbalance. This can manifest as irregular cycles, cyclical acne, and facial hair growth. Importantly, over a third of women wait more than 2 years to receive a diagnosis, significantly delaying the introduction of management strategies. And 3, wellness. We know that these hormonal fluctuations impact sleep, exercise, mood, and skin. So while we believe that these insights are important to every person who menstruates, throughout our customer discovery, we discovered a strong unmet need among women with irregular cycles. 25% of US women have irregular cycles. For these women, cycle tracking via calendar-based apps or temperature-sensing wearables was not proving useful or accurate. In particular, polycystic ovary syndrome, PCOS, emerged as a menstrual condition that women feel uneducated about and struggle to manage. PCOS is also a leading cause of cycle irregularity and infertility. Importantly, 1 in 10 women in the US have PCOS. However, these numbers are rising at an even faster rate in the global south. PCOS is the most common endocrine disorder of Indian women of reproductive age, with prevalence increasing by 86.9% from 1990. 1 in 5 Indian women has PCOS. And just to gauge scale, that's approximately 75 million women. Combined with delays in diagnosis and resource constraints, Indian experts have warned that India is unprepared for a PCOS crisis, demonstrating that this domestic unmet need has global amplifications. For this reason, we're adopting a US-India dual market strategy. So initially launching in the US, we are looking initially at women with PCOS. Compared to wearable comparables such as the Oura Ring, our model, a hardware SaaS combination with a $30 monthly subscription, is cheaper to start and as a toothbrush, stickier to keep. PCOS as the first segment in the US represents a $2 billion market opportunity. However, when we expand to our Indian market, the truly global potential of this technology emerges. Driven by rapidly changing cultural and behavioral trends, the emerging female middle class now has more purchasing power, increasing consumer demands for previously stigmatized categories such as women's sexual and reproductive health. In fact, India's cycle tracking market has increased by approximately 22.6% annually and is expected to triple by 2030. As an Indian woman with cousins in Delhi myself, I've seen firsthand how this is driving significant consumer change. Delivering a tool like this to Indian women represents a $26 billion market opportunity. Importantly, the sheer scale of the market means that we could potentially adopt lower subscription costs, increasing affordability and market share. So what do we need to get going? Well, this summer is crucial for us. We've already validated that we can pick up the hormones we're detecting in saliva, and importantly, that we can collect a large enough sample during brushing time. Our next scientific milestone is fabricating a sensor small enough to fit within a toothbrush head. This milestone takes us from an alpha glucose brush to an alpha sensor, unlocking the capacity to go out and raise angel funding. It is truly a game changer. At Fariva, we're not just another cycle tracking company. We're a women's health company. And while women are 50% of the population, we are 100% of the life force. Women are the future. For that reason, Eva is committed to bringing women back into their bodies. For my grandmother Eva, for everyone.
Nicely done, nicely done. So we are doing well on time, and you guys are doing amazing jobs with your pitches. So I do want to give enough time for our judges to really ask questions, and you can explain what you're doing. So we do have the time. So who wants to kick us off on this round?
Hi, that was a great presentation. I have a few questions. I'll start off with how it functions. Is the saliva extraction not affected by toothpaste?
So toothpaste is a variable that does affect the measurement currently. The goal for us is membrane technology. So part of our scientific roadmap is sensor fabrication, but also membrane tech. And we have a collaboration with a professor at UConn, Jeffrey McCutcheon, who's an expert in membrane separation. And what this membrane will be designed to do is it will exclude things like toothpaste, but also food in your mouth, potentially bacteria in your mouth, to only allow the hormones that we're measuring to transfer through. We're confident we can do that because we are looking at membranes that select and exclude based on mass and size. And we've tested that in the lab and validated that the hormones that we're detecting fit those parameters.
And the results is connected to like an app. How is the data being extracted?
Absolutely. So the data is being transmitted via Bluetooth to an app on the phone. The app is embedded with several different functions, including our Ask Eva application. What does that mean? Well, we're adopting a RAG LLM AI structure to scrape verified, reputable articles from PubMed and various academic journals so that you're getting this information, but you're having a way to understand it. And so what we will do is customize along health literacy levels and regurgitate this information to users in a way that they can understand. For example, it might be, as a professional athlete, we know that estrogen affects muscular laxity. That means that that's your greatest time of ACL tear is around ovulation. So let's say you get a reading that says your estrogen is quite high and you go, okay, so what do I actually do with this? Well, you can ask Eva and say, I'm a professional athlete, what does this mean for my exercise? Well, today, let's say, Wendy, you're at your greatest risk of ACL tear, so make sure that you use prevention strategies or you don't push yourself too hard to prevent a potentially career-threatening injury.
Very interesting. Is this already built out?
We already have the basics of the app built out. I'm happy to give you a demo after this conversation now. And what we're doing currently is the interface of our app is accorded to our glucose toothbrush. So this here is our glucose version. So it shows the sugar that's circulating within your body and also allows symptom logging for things such as shakiness, etc.
Okay, I just have two more quick ones. What's all included in the $30 per month? And have you looked into intent to buy?
Sure. So we've looked into intent to buy. I believe here I've got my market research. Here we go. So we did the NSF Regional Customer Discovery Program, and I'm excited to share that we've been promoted to nationals, and we'll be doing that over the summer. And within our regional discovery, we found a willingness to pay between $200 and $500, averaging around $300. Now, in terms of what's actually included with the subscription, everything. We're subsuming the cost of the hardware into the subscription so that there's no major upfront costs. We're confident that we will still be able to create a sticky data moat because every brushing session increases the accuracy of the model to your specific body. So if you use the device for a 1 month, 2 month, 3 month, every month you're getting a better product.
Okay, and my last question, what does it look like at the end of the summer? What would be the best case scenario? What are you hoping to achieve?
The best case scenario at the end of summer is we have a basic alpha sensor that can detect 1 to 2 hormones in saliva. In conjunction with funding that we've received from the summer fellowship, we also want to kickstart our membrane testing so that together we would have a basic alpha prototype that de-risks the technology sufficiently enough for us to go out and raise an angel round.
Hi, thanks for actually focusing on women's health. It's much needed, and I like the trying to go out of the box. So I have actually 2 fundamental questions. One is on the research side. Saliva as a biomarker has had a choppy history. if you validate it against the gold standard, how are you going to bridge that gap, and what's the data of validation that you have? Because that's going to be critical to actually prove in the market that you can screen, because that's what you're doing, very clear screening. The second is a more fundamental question. You talk of India.
Right.
There's a big problem if you're not part of a care gap system, because care gap closure is a big thing. Okay, you diagnosed 6 people who require to have OB follow-up. There are not enough OBs. You're not part of the system. System closure is actually creating more of a problem in frontline screening. Cervical carcinoma is a great example. How do you really integrate into systems when you are standing alone with a piece of technology?
Sure, perfect. So I'll start with your first piece about the validity of saliva. So we've actually been picking up these hormones in saliva from the 1980s. Now, I understand that there is a difference between clinical gold standards, and whilst there has been some research that has been contradictory at times, there is a growing groundswell looking at saliva as a non-invasive methodology. Now, what's really important is we need to look at feasibility and practicality. So absolutely agree that blood and urine is a gold standard, but realistically, a person is not going to go take their blood every day. And we're also probably not going to have high compliance with someone urinating on a stick every day either. What's important is getting these people some kind of data, which they might go and validate with their GP or their primary care provider. And the primary care provider might turn around and say, great, let me validate this with a blood test. But instead of that person doing one blood test every day for 30 days, they've done a saliva test at home for 30 days with one validatory blood test. And that gives the physician the peace of mind that the data that we've collected matches that from their blood panel. We're also working quite closely with physicians. So as you'll see here in our team, our medical advisor is Dr. Alavash. She's an OB-GYN with specialty in PCOS. And so we're designing this product to meet industry standards and working quite closely with physicians to understand what they need to see to trust a product like this. Now, as for the India market question, great question. We've been working very closely with intermediaries within the Indian ecosystem. So we have a connection who has recommended a go-to-market strategy in India that focuses specifically on partnering with clinicians and fertility experts, et cetera. So actually working within that system as opposed to potentially selling direct to market as we would in the US. What that would mean is that we would partner with fertility clinics, hospitals, potentially rural settings as well, depending if we can get government subsidy, so that these tools are being rolled out by physicians to individuals, and they can come back either on a monthly, fortnightly basis to get some kind of care.
Amazing. Thank you so much. Nice work. I love these innovators. We've got more coming, so over to microclinics.
Thank you so much. Good job.
Let's give him a hand.
Do you want to flip or should we take it like this?
All right. Good afternoon, everybody. My name is Rishi.
Hi, I'm Shaunak.
And we are the founders behind the Microclinic Project. Our story begins with my grandfather. He was a rural clinician in Bangladesh for over 50 years, practicing in the clinic that you see before you right now. When I was younger in the summers, I would spend my time sitting beside him as he saw patients in this clinic and on motorcycle. Even at 83, he would travel out to see patients in the rural villages where the need was. And he understood that millions of people die every year from diseases we can prevent and we know how to treat. Not because the science doesn't exist to treat these patients, but because the lack of delivery in that last mile does not exist. And that's why we started the Microclinic Project. Bangladesh faces a dual burden of disease. At the same time that 120 people are dying every single day from infectious diseases in Bangladesh, 67% of patients are also dying from complications of non-communicable diseases. You cannot take these as separate issues. Parachuted in programs that are vertical healthcare campaigns that come in and target one section of disease, or maybe target a handful of small infectious diseases, miss out on the other large portion of that disease burden. And in fact, the interactions between this disease burden is what is critical to understand from a patient care standpoint. And so what these patients don't need is another parachuted in solution that can claim to solve just one or eradicate one set of disease. We've seen that, and ultimately we're coming up on the limits of that expertise. And what these patients really need is an accessible system of primary care to see them and enabled to manage their conditions, both infectious disease and non-communicable disease. But Bangladesh isn't starting from zero. It has one of the largest community health worker programs in the world, over 130,000 CHWs. But these networks were built in a time of vertical healthcare programs. They're not equipped, they're not trained, and they're not paid to deliver real primary care. And we've seen what happens when these, what are treated as part-time employees, lose the political and economic will to sustain them. Nearly half of the CHW jobs in country have been lost in the last decade. We see this as a massive, neglected opportunity. These community health workers have trust in communities. They are already going to deliver care in the last mile. We see them as an opportunity to empower them with technology to deliver frontline primary care and serve as the backbone of an accessible system into the larger system of care in Bangladesh.
That is exactly what we set out to do, to empower community health workers to deliver primary care in the last mile. Our hardware has a full suite of diagnostic tools to deliver real primary care at the front line. This is in tandem with our software, with the clinical decision support system and patient records that move with the patient. And ultimately, this is driven by our economic model, which builds real careers for community health workers with a stable income that sustains care delivery. Our software is fully HIPAA compliant, which meets the highest standard of patient data security in the world, and is FHIR interoperable, meaning we can fully integrate with existing hospital and government systems. We have built a custom, evidence-based guided decision support system based on peer-reviewed clinical calculators capable of automatically generating clinical flags. And lastly, we built in collaboration with community health workers in the front line with native language support and offline compatibility. Our hardware is equipped with a full set of portable diagnostics, from basic vitals to advanced blood testing. Our 8-hour battery life keeps CHWs connected with cellular and satellite connectivity. Furthermore, all of our components are fully modular and repairable and can be both repaired and replaced in Bangladesh without taking the full kit out of service. And lastly, every component of our hardware is manufactured in Bangladesh, keeping our costs low and fully grounded in the local economy.
So let's see what this system actually looks like on the ground. Let's say a community health worker travels out to see a patient in a rural village. Shaunak, how about you tell them what's happening?
Yeah, absolutely. So our system first guides the CHW to input basic vitals. And this creates an initial flag for both NCD and infectious diseases. And we can see on the top left an initial set of flags that have come up. Next, the system guides the CHW into a basic medical questionnaire that we built using peer-reviewed clinical calculators and builds a more comprehensive patient medical record. Lastly, based on our initial vitals in this medical questionnaire, our system automatically generates additional tests to build the complete set of a patient's medical record.
Ultimately, these networks don't exist in isolation like they would in a traditional vertical healthcare campaign. It's true. Let's say this patient needed a higher quality of care. They needed more diagnostic testing or more imaging. These CHWs are not abandoned in villages, but they exist in the context of rural clinical hubs where they can accelerate patient care and elevate it to the next level if needed. Ultimately, rural clinic deployments form the foundation of an accessible system of care for 67% of the population in rural Bangladesh. But additionally, what if this patient needed to travel to a regional health center? Or if they needed specialist care in an urban hospital? This data moves up the system. It is FHIR incompatible. It is able to develop longitudinal health records for these patients. But there's also additional value in that record that we've created beyond the health of the patient. Governments and international organizations require and use outdated methods of disease surveillance. That level of disease surveillance is typically done on paper through mandatory reporting and extrapolation, and often misses the real population level burden. By providing real accessible data for them that provides real-time population level support, we provide them subsidies that then can feed down and support community health workers at rural villages, providing them administrative portals that provide infection trends, disease surveillance, and additional markers that allow them to help and better deploy their own healthcare systems.
Ultimately, we've created accessible and consistent primary care for patients on the ground. A real understanding of disease burden for governments and NGOs, and a stable career for frontline workers. Currently, we're operating out of 4 frontline rural clinics with 35 village deployments, currently operational for 16 weeks, and we have accumulated nearly 2,000 total patient consults.
We are working with partners all across Bangladesh and the world, including the 2 largest employers of community health workers in Bangladesh, the Ministry of Health and BRAC. We are working with them to empower their existing networks to deliver the critical primary care that these communities need. Additionally, we have support from Bangladesh medical advisors and those that are in the United States. And crucially, there are dozens of small, fragmented health initiatives that provide some amount of care to certain regions. We aim to unify them and scale them, providing them the tools and technology to provide primary care and the economic model to sustain that. These range from small university nonprofits to floating clinics that travel across the deltas of Bangladesh. These are a way for us to scale rapidly and meet the disease burden as it exists on the ground without having to rebuild up an entire system and instead integrating the fragmented pieces of care that already exist. Our team spans expertise from across the Yale ecosystem, including the School of Public Health, the School of Management, the School of Engineering and Applied Sciences, and the School of Medicine. And this has driven our momentum. In the past 9 months, we have gone from ideation to actual operation in Bangladesh. And over the next 12, with your support, we plan to grow in 3 key phases. First is expansion. We have existing partner networks that have memorandums of understanding that are awaiting the capital so we can provide them the tools and technology to deploy our primary care system. With this, we plan to target 25,000 patient records in 6 months. Ultimately, this provides validation, building a peer-reviewed evidence-based understanding of disease burden and validating our microeconomic model. We are actively pursuing IRB approval with the support of Dr. Kabe Kushnut at the School of Public Health to provide this population-level analysis. And additionally, we're using all of this data to begin to think about our sustainability, validating that microeconomic model, securing contracts that we're already negotiating with large regional players to provide them the data population statistics that they need. We have seen firsthand how consistent, accessible primary care has the revolution to change lives.
And we know that this problem isn't exclusive to Bangladesh. Across the world, patients need real, accessible primary care coverage.
And ultimately, our mission is to empower people on the ground to deliver life-saving care in the last mile, 1 microclinic at a time.
Thank you so much.
Thank you, everyone.
Nice work. So just maybe a couple questions. They were a little over, but I wanted to let them go through. So maybe 2 questions.
Sure. So that was wonderful. Thank you. Appreciate the focus on community health. A couple questions. One, can you talk a little bit about the hardware?
Yeah.
I noticed in the picture that the community health worker was using a smartphone. So are all of the components of the package linked with the smartphone? That's one question. I appreciated also that you worked with community health workers in designing this. I was wondering if you could talk about any of the challenges that you may have faced in that, because in my experience working with community health workers, even smartphone apps can be a challenge sometimes. So wondering if you could talk about that, and then connectivity as well.
Take connectivity, and I'll start with the community health workers.
Yeah.
So great questions. Thank you so much. So the first thing is the hardware, right? So again, this is not something that is entirely proprietary. We're not building a glucose sensor and then trying to deploy it and get FDA approvals. These are things that we're buying off the shelf in country, right? And it's not necessarily that these are novel technologies for them. These are things that are the standard of care in diagnostics here in the United States and diagnostics there, right? But the issue is that the capital doesn't exist, and also the way to provide a system in utilizing the analysis on that doesn't exist. And so when we spoke to CHWs and talking about, when I was in operations in Bangladesh and we were talking to these community health workers, especially in rural clinics, and you ask them, hey, have you considered charting? And the first question they say is, why? And that's not a question that you're normally prepared to answer, because you're like, why wouldn't you? But the issue is that you have to be able to think about their workflows. And so we are built off an open MRS backbone. That's something that is internationally standardized and something that's open source. But we've worked with them to say, what is the workflow that is most applicable to you, right? And what's something that you can understand? What's something that you know why we're taking these basic vitals? You know how that builds into this. And you can live track what individual things are being updated. And that was really beneficial for them. And then additionally, as we continue to scale, these community health worker networks can be very easily trained in the software. It's not something that necessarily requires much more than applying the diagnostic technologies. And then that decision support and also the connections with rural healthcare clinics are what provides them the support they need to do that. Shanik, if you want to
Yeah,
talk more about
absolutely.
connectivity.
In terms of connection, this was a major choke point where, like, we need to make sure that the system actually works when the community health workers out in the front lines. So we've addressed this in, two main ways. First one being majority of Bangladesh has cellular connectivity, and we've equipped our portable hardware kit with a mobile cellular device to ensure connectivity. But in the case that we don't have cellular connectivity, we've built our own custom module to offline cache our files. So essentially what would happen is the community health worker would go out into the clinic, and if they weren't connected, our system, the laptop that we've deployed in this instance, would locally cache the files, and when the community health worker comes back online, it would automatically push these files onto the online system.
Great, thank you. So just for parity, a brief question and then a brief response, and then we've got to go to our next.
Yeah.
I mean, you solved a lot of problems in terms of systems of care. Essentially, you are a technology middleware between the acute care and the frontline care. My question is really focused, two parts to it, but I don't know if we'll get through both. The first is the technology itself. When you talk of clinical decision support, you have to train your algorithms to get there. Right? That's a big task, especially when it's CDS. The standards are high. Talk a bit about how did you train it and how did you validate it? Because false positives are a big burden to a system like Bangladesh. You suddenly see patients that you shouldn't be seeing, and the system is not set up for it. I know Bangladesh well. Second point is, what are your different revenue streams? Who's paying you? You talked of data, you talked of population health, all of which are possible, but how will you build
Great, thank you. So 30 seconds each.
Yeah, very quick. Okay, so as far as the clinical workflows and the guided decision support, that's not something that we are regenerating, right? That burden of knowledge already exists. If you go to mdcalc.org, it's what I use when I see patients at the New Haven Free Clinic. They're basic clinical calculators. Essentially, it's taking diagnostic support and creating risk profiles and basic threshold values. It's something that EHRs already do internally. It's something that we're adding on additional calculators in order to do that. Ultimately, long-term, that's something that we're developing in partnership with our advisor team to have more advanced clinical workflows. But ultimately, as you just said, we want to prove that this data is rigorous and it's reliable. And so that requires us to build on peer-reviewed evidence. For the second part, for revenue streams, ultimately, we talked here about that data structure, right? But we mentioned microeconomics, and that's a key part in this. And that the software that we're building for enterprise level, so if you're a rural health clinic, we're building software to help you with your billing and your administrative work, and that's valuable to you. And that's something that they have already expressed. We're being paid and we're generating revenue from them licensing that software to being used. Additionally, currently these camps are operating in a free capacity to build trust in communities and build a patient base. But this is something where the cost of an average primary care consultation in Bangladesh is 500 taka. At scale, and at this current scale, we're able to provide it for 50 per patient, so a tenth of the cost. And so that's something that, as we're thinking about scale, as we're thinking about our microeconomics, we can run these little experiments and thinking about how revenue works outside.
Wonderful. Thank you so much. Let's give them a hand.
Thank you, everybody.
Thank you.
Nice work.
Thank you.
Yeah, good job. Okay. Yeah. All right, good job. Yeah, you go that way. Yep. Okay. Last but not least, our closer, Pulse. Come on up. Yeah. Good.
Awesome. Can everyone hear me? Hello. Hi. Good afternoon. My name is Jemaja Caraballo. I'm a second-year student at the Yale School of Management, a U.S. Army veteran, and the founder and CEO of Pulse. We are the digital green book of healthcare. And for those of you who don't know what a green book is, I'm happy to tell you. The concept came about in 1936 by a postal worker by the name of Victor Green, and he created a navigation tool that helped people of color safely travel throughout the country at a time of arguably highest racial tension. And that's essentially what Pulse is, a navigation tool that helps patients find care that aligns with who they are. Awesome. So before I hit the data points, I want to go and define something. Cultural concordance. And what cultural concordance is the alignment between patients and providers based off of shared cultural background, language, and lived experience. Now, the reason why I wanted to define this is because the lack of cultural concordance in this country has led to huge racial disparities in the healthcare system. For instance, 1 in 3 BIPOC adults avoid care due to culture or language barriers. The maternal mortality rate of Black women alone in this country is 2 to 3 times higher than that of Caucasian women. And out of everybody that we surveyed, 83% of BIPOC adults felt rushed or dismissed by their providers. When you expand that in the United States, that's over 60 million people. And if they were able to go and pledge about $50 a year to a platform that can promote cultural concordance, we can improve healthcare outcomes by 30 to 40%, while also finding an addressable market of close to $3 billion. This is where Pulse comes in. Pulse is a matching platform that helps patients find culturally competent providers, not only on the clinical side, but also on the holistic provider side, because healthcare comes in all forms. After many iterations and partnerships with providers in different states within the country, we have now validated and built out a full beta that is open to use for proof of concept today. And utilizing it is as easy as 3 simple steps. 1, tell us who you are and the care style that you're looking for without disclosing your long history medically. Then 2, see your matches. Our smart matching algorithm creates a curated list of providers within your area that most closely match with your care style. And then 3, book and connect. Our smart matching algorithm was derived after extensive research through clinical white papers from the Agency of Healthcare and Research Quality, as well as with interviews with patients and clinicians, to include the GI oncologist over at Yale Smilow Cancer Center and the chief medical officer at Fenway Health. We also added an AI layer to improve the balancing of the algorithm and also for it to learn from the algorithm, so each match gets that much better and that much stronger. Now, for the competitive landscape and our 2 main competitors, ZocDoc and Healthgrades. Without going down to the list, I'll answer a question that some of you might have. Why wouldn't ZocDoc and Healthgrades essentially do what we're doing by tomorrow? I'll be happy to tell you. Essentially, them defining it to this demographic and this focus would involve them completely restructuring their data model, their relationships with providers, and overall their revenue logic. And that is a completely different company with a completely different philosophy. And thankfully, that's where Pulse comes in. Also, in conjunction with that too, our moat is the proprietary data that we gain from each questionnaire that gets filled out with each matching, booking, and connection. So the algorithm gets smarter. Now for the ask. In regards to the 25K, we have 2 primary focuses for it. One is the core innovation in R&D. As we continue to utilize our smart matching algorithm in conjunction with the AI navigation tools, we want to make sure that every match gets smarter, every experience between patients and providers get better, which will then allow us to have provider acquisition as well as grant preparation and to scale operationally. However, we can't do that without number 2, ensuring that we are legally compliant with HIPAA, not only on the software side, but as well with our business model as a whole. And now to go and touch on our revenue model. Now we have 4 revenue streams, starting in succession of 1. In year 1, our core philosophy is that we want to go and reduce as much of the cost barrier on patients as possible. So the first year, we'll be charging a 10% booking commission fee from each booking that's done between a provider and a patient. Then in year 2, we will then open up our other 2 revenue streams, which will be our annual subscription fee for patients of $49 a year, because we understand that healthcare needs are sporadic and not always consistent, as well as employee partnerships that will range from $25,000 to $50,000 yearly. Yale University and the City of New Haven are our anchor targets. And then in year 3, we will then open our last revenue stream, which would be managed care organization contracts, or MCO contracts, which will range from about $25,000 to $50,000 annually as well, with Aetna Medical Health being our focus target in year beginning of 2027. And now for the team. As you know, I was a military officer that primarily focused in tech as well as operations. And during my time at Yale School of Management, I have the business acumen and the operations and tech experience to ensure that this is scaled properly and safely. Cameron Ayala is our clinical co-founder that helps provide legitimacy to Pulse, and it'll help us root out any frictions that providers may have navigating the website or the AI tools, and just the relationship between them and providers and patients in general. And then Laurel Hunt is our marketing and compliance lead. She's had over 10 years of marketing experience, and she'll also be joining UC Berkeley as a law school student. And she is the person that best understands how to promote the message of Pulse, how to engage with our customers, and ensuring that we stay legally compliant. Everyone deserves healthcare that matches who they are. Please help us promote the platform to deliver it. Thank you.
Thank you so much, Yema, and also thank you for your service. We appreciate that, and we don't take that for granted. So over to the judges.
Absolutely.
Wonderful, wonderful presentation. One of the big questions I had was, how did you train the AI? So just from start, I'm guessing you're using a third-party model and then training in an API layer. Can you just talk to me a little bit about how you started training the AI?
Yeah, of course. So before we even touched the AI, we wanted to make sure our algorithm was solid. So based on the clinical research reporting that we had, building the weights for that, we wanted to make sure that foundation was solid first before we even included AI. I know people in the audience know as well as I do, AI can hallucinate a lot. And when it comes to patient-provider information, we want to make sure that this is scaled as safely and as smartly as possible. So when we taught the AI, we actually partnered with a few clinicians over at Lone Tree, Colorado, veterans and colleagues of mine. And what we did is we entertained the idea of about 100 proxy patients, either some of them are interested or not interested, to utilize the smart matching algorithm to make sure that there was consistent alignment with what the algorithm was doing as well as what the AI was picking up on. And then after every iteration, we kept focusing that channel to make sure that it had the results that proved what we needed.
Very cool.
Awesome.
Thank you, because I think you're solving an interesting problem that you're matching provider to patient with the cultural fit, and that has many benefits. My question is about the availability of providers. So you get a great fit, getting an appointment is a very different thing.
Yes.
Patients are waiting all over the world, and in fact, if you want to scale this outside the country, they're waiting months to see a primary care physician. They're waiting over a year in Canada to see a specialist. So how do you reconcile a match with appointment? Because then you're not actually matching, you're getting the first available appointment, which is not the best match. That's the first real concern of mine. The second concern is these sorts of algorithms are predicated upon the fact that you are matching to physicians. Have you thought of matching to nurses or alternate care providers because they are more available? And how do you expand the care pool in your algorithm?
Yes, no, those are two great questions. Thank you for asking. Now, in regards to global expansion, of course, myself and my team have, of course, considered that. And I just kind of wanted to show, in regards to where we're looking to go and build globally, we understand that HIPAA compliancy, legalese, it's all can be like essentially a mixed bag. So our primary focus will of course be Canada as well as Europe, specifically London. And when it comes to making sure that they can actually get booked an appointment, how we have it built out is that there's seamless integration with the onboarding system that providers would already have. Even as something as simple as them being able to extract all of the appointment data onto their either Google Calendar or Apple Calendar, that's already built in there as well. Also on the patient side, on the provider side, there's basically a dashboard that gives them constant alerts of when they have double bookings or when there's bookings done on their site versus the application that they use for that integration. So we have that as basically a stopgap to ensure that they can make their appointments and also mitigating any double bookings.
I'll just ask another quick question. So you're selling to insurance and managed care organizations. Yes. They're really hard to sell into for, I think, maybe two reasons. One is that, they see something that they like. They might build it in-house. or that, you know, it's just not absolutely necessary for them to have this, and so it's really hard to get them to pay for something like this. Have you? What are your thoughts on that? I'm sure you've, you know, had thoughts on both these things.
100%. So we're hoping as we expand in iteration our revenue streams that the patient engagement that we get within the first couple of years will speak for itself as to why insurance companies would want to pay for it. Also, when it comes to how we're looking at building out the model, we're doing it in mind of the HEDIS value equity gap, basically the scorecard that insurance companies use to show if whether, lack of a better term, the juice is worth the squeeze for insurance companies to go and pay on behalf of the members. So when we're thinking about the algorithm and thinking about what key care styles that we want to have targeted and displayed, it is with that in mind, the HEDIS value equity gap.
Thank you so much. And that brings us to the conclusion of this session. So let's give all the innovators a big hand, because that's not easy. I love this time of year. So just to give you a sense of the process, we had over 70 applications for this prize. And then we had 32 semifinalists, and the 4 you've seen made it through all of that. You could see the diversity of ideas. You could see everything is mission-driven. It's global. I mean, this really is just highlighting from across campus how Yale students are thinking about impacting the world. So I'm really proud of all of you for the important work you're doing. And unfortunately, we can only have 1 prize, but all 4 of them are winners in my books. And I'd like to say that if any of you find anything that any one of these groups is doing interesting, please reach out to them, please find them, because all 4 of these groups are going to keep pushing on this work. It's not just about this prize. So I'm sure they'd be happy to speak with you. Let's not forget our Audience Choice Award placards. If you guys could please pick who you think the Audience Choice winner should be, mark that on the card, and there are boxes in the back here, ballot boxes on this side and this side. And with that, thank you for joining us, and have a great rest of the day. For my finalists, stick around.